So here's the predictors of success. So there's 3 factors of success that add up to 100%. The patient factors. As I said, you want to pick the right patient with the right medical conditions and put them in the right box. Are they outpatient? Are they the 1 day? Or are they the extended day? The surgeon factors. You have to have a minimal volume. Do we know what that is? It's probably not 1,000, but it's not 50, but it's probably somewhere in the middle. You want somebody that's doing a couple hundred knees a year to have the experience. The surgeon needs a team like I showed you. You don't want to walk into the OR and have Betty, who just did an aortic aneurysm yesterday, or she was up all night doing a trauma case. You want your team that knows the steps that you don't have to ask, and you want an institution that's committed to this. Everybody has to speak the same language. So when you're in the recovery room, you know, within an hour they're up in a chair and they're walking and they're not saying, you know, are you going home today? Are you not going home today? So all of those things, each one of those is 20%, and that adds up to 60%. So what's 100%? The 100% comes when you put all those three things together. Each one of those is 20%, but when you have all 3 of them, that's what makes it work. So this is not a turnkey operation. You just can't tomorrow turn around at an institution and say, we're doing this outpatient. You really have to have the patient selection tools. We start our non-narcotic pain management 2 days ahead of time. So you really have to get the body used to different type of non-narcotic pain medicines that act at different part of the pain pathway. This sounds simple, but we haven't figured this out in the last 30 years, but it's absolutely amazing to see how little pain patients can have without taking Percocet, Vicodin, oxycodone if you give them different analgesics, and I'll show you where they work at the skin level, the nerve level, the spinal cord level, and the brain level. Because narcotics work up here. They do nothing for down here. So you have all this pain that gets to your brain, and then they just zonk you. And then that zonking causes, you know, lethargy, falling, constipation, hypotension, all that stuff. So again, the decision for surgery is the ideal location, how long you're going to stay, what's going to happen at home, where do you live? Do you live in a ranch home? Do you live on 3 floors with 6 cats and your crazy uncle? I mean, all those things are critical because you don't want to do an outpatient procedure and send them home and they live with, you know, nobody but, you know, Muffy the cat or something. So, and then this is our patient selection tool. If you come to, and you're welcome to come to our joint camp. Melissa isn't here, but she runs it every other Wednesday right here. It's for our surgical patients, but she'll have 15 to 20 people, but the public is invited because she'll repeat all this sort of stuff, and you can go over our patient selection tool. You can see what we, you know, so if you're having hip surgery, knee surgery somewhere else, you're welcome to use our preoperative, you know, all we want to do is help patients. You can take that to your doc and say, can I be on these preemptive medicines that don't require narcotics? How about, you know, my DVT prophylactic? Do I need Coumadin or Xarelto? Can I just take aspirin if I have no other risks? But again, not everybody is a candidate. If you have, you know, certain types of arrhythmias, atrial fibrillation, dementia, bad sleep apnea, severe obesity, uncontrolled diabetes, cancer. No, care partners are critical to this. So you have to go through this with a care partner. Somebody has to be there with you, listening to you, have more ears, go to joint camp, be with you in the hospital if you go home 2 hours later. So that's the critical part of this, is patient engagement, educating them and their friends. So, and infection control. We have this all sort of protocolized. Everything is on paper. Everybody does the same. We have a 10-step routine to avoid infection. It's not we give you a little bit of penicillin and hope you don't get infection and slap some iodine on you, but we use spacesuits. We limit traffic. We have a lot of visitors that want to watch what we do. If they want to come in the room, they have to put a spacesuit on. We minimize anticoagulation. We talked about Coumadin and aspirin. The problem with bleeding is it increases your infection. You have a knee full of blood. People with hemarthrosis, or blood in their knee that needs draining, has a higher incidence of infection postoperatively. Bacteria love blood. It's like bacteria pudding. Tranexamic acid. We were vilified for bringing this stuff in. They said, you can't you really can't do this. This was a dental pharmacologic agent that they used to prevent bleeding in teeth. But the heart doctors used it all the time to prevent bleeding in the heart. It's always off-label because to get something through the FDA, they just want to get it through the FDA on one thing. Now it's the standard of care, tranexamic acid. Everybody gets it intravenously. They get it in the knee joint. It almost eliminates excessive bleeding. Nasal iodine, if you test positive for MRSA. We have people washed for a couple days ahead of time. Dilute betadine wash. These are all things that are proven. We have this pulse lavage. That's our equivalent of a car wash, in the OR. Antibiotics. Then we have the silver dressing, which in itself decreased the incidence of wound infection by a factor of 4. So patient education is critical. We go over all these things. Patients have to take a test so they know what to do if they get some nausea, if they can't pee, if they have a history of prostatitis. It doesn't mean you have to be in the hospital, but it's all about preempting problems and predicting problems as opposed to the traditional approach is we put you in the hospital. If you had a problem, we treat it. If you have pain, we gave you narcotics. If you couldn't pee, we put a Foley catheter in there. If you were, if you got sick to your stomach, we gave you Zofran. So now we sort of preempt all this stuff. I mean, the whole paradigm has shifted. If anyone's had surgery, remember you shouldn't eat or drink after midnight. That's gone away. Now we want you, now we want you to drink right up until 2 hours before surgery, not a milkshake from McDonald's on the way in here, but anything clear, Gatorade, water, tea, coffee without milk, because we want you hydrated. If you're not hydrated, you have an increased chance of hypotension. So some people, they'll eat dinner, they may not be operated on until 24 hours the next afternoon. These people are dehydrated, your glucose is low. You think of all the things that were crazy that we used to do. We used to stop aspirin. We used to stop fish oil on people because we thought they would bleed. In our operations, you don't die from bleeding, you die from clotting. A clot goes to your heart or your brain, you have a stroke or a heart attack. So now everybody's on aspirin. We don't stop it ahead of time. But that culture is hard to change. People come in and they say, yeah, I stopped my, why? Well, somebody told me to stop my aspirin, or I didn't know. These things in medicine, that are again, part of that conformity line that you walk down are very, very, very hard to change. So, so somebody asked the question, we have smaller incisions, that improves the quad function. You can walk right away. We don't use nerve blocks anymore, femoral nerve blocks that last 2 or 3 days because you can't stand, you fall down. Less pain, smaller incisions, better range of motion. And so here's major studies that showed 94% of total joint arthroplasties have no major complications. So 6% can have a major complication. So the key is to look for those 94% and say, which 94% aren't going to have a problem? Let's look at their medical profile, and they fit into limited stay, rapid recovery, or outpatient. So you don't treat everybody like they're that 6%, that can have a problem. I'm going to kind of end with this paradigm change, where everything, our average length of stay is 1 day. We have some with no days, meaning 2 hours. We have some with 2 or 3 days. But we've completely changed that. And that's the whole idea of this rapid recovery program. Here's our multimodal pain approach. It involves Tylenol, nonsteroidals, COX-2, Celebrex, gabapentin, or Lyrica, steroids, spinal anesthesia. We don't use general anesthesia. Peripheral nerve blocks we've kind of gotten rid of. And there's this new periarticular injection, which is a new type of Novocaine, which lasts 2 to 3 days. Unlike the dentist's Novocaine that wears off in 2 hours, this wears off in 2 to 3 days. So one of the big advances is we can inject the capsule, not your whole leg. So we have to educate people and say on the 3rd day you may have more pain at home than the 1st or 2nd day. So once they know that, they can take some more pain. And they all get a little bit of oxycodone to take home in case at 2 in the morning they're cursing us and say my knee hurts. But in summary, the multimodal pain approach is preoperative. We have a menu of medicines we start 2 days ahead of time. None of them are narcotics. Intraoperatively, you get 4 different medicines. Postoperatively, we start them again, and at discharge, you continue them for 3 weeks. And they all work at different parts of the pain pathway, at the skin, the spinal cord, and the brain. So, this is one of those things that we sort of figured out to avoid narcotics, and we know where to inject the knee, and this last 2 days. So, any questions from the audience for me or the team? Yes?
I was trying to pay attention to what you were saying about Medicare patients. Is it the practice of procedures all the same except they're going to be in a minimum of 23 hours? Or are there differences in how you approach a Medicare patient?
So they have an insurance requirement where they do not have an outpatient code, meaning that you pre-cert a patient with different insurance carriers. You can't pre-cert them to do an outpatient total knee. If you had a partial knee, we could do you at an ambulatory surgical center, but it's basically the coding of CMS that they don't have a code. We have lobbyists in Washington. I mean, our group looks at all these aspects, and they're going to change it, but it has to be attached to some bill, and you know how that goes.
But so a Medicare patient will stay at least 23 hours in your hospital?
So they have to stay, it used to be a 48-hour rule where they had to stay 48 hours, but now at 24 hours, if they're ready to go home medically, they can go home.
Okay, but as far as the way you proceed with their operation and all that?
Exactly the same. They come to joint camp, they do the preoperative medicine. An hour later, they're up walking, in the hallway. So our rehab has evolved. But when our patients go home, what we like to do is start them as outpatient rehab the next day. So if you're going home as an outpatient, we want you up in the car going to outpatient rehab, just like if you had a knee scope or an ACL done. Now that's not always the case. Sometimes people want to go home, they have a care partner, and they live rurally, and we could do home therapy with them, or they can't get a ride or something. But in general, our protocol is discharge to home the same day, start outpatient therapy the next day. Every knee operation we do this same rapid recovery program. And we have over a dozen partial revisions or whole revisions that we have sent home the same day. But we tell them, the percentage of those people, it's more likely that they will stay because there's more surgery involved. But in revision surgery, you can, revise the bearing, 1 part, 2 parts, the whole thing. So it really depends on how much surgery is involved. But again, Dan Hilt, he was we revised him from a partial to a total, and we treated him just like these folks. They went home the same day. Again, we don't use general anesthesia. We don't use narcotics. So a lot of people that have a history of an adverse reaction, it was really the narcotics that were involved. So, people are awake talking to us if they want to listen to machines and drills and saws, but most of them choose not to. Yes, sir.
Is there an age at which same-day replacement is not possible?
There's no age at which it's not possible. There's some common sense components to it. It's really physiologic age and your medical comorbidities. So, and it's almost a combination of that and your insurance criteria. So most people, once you get, over 65, are Medicare. Yes, sir.
I noticed you had on there obesity. I'm slightly overweight, like about 80 pounds. Would that hamper me from getting it?
So it's, join 70% of America. Yeah. So it's not a contraindication in itself. Again, we have a formula, it's called the Charlton Index. And, it's like obesity, depending on what your BMI is. It's different if you're a 50 BMI, 200 pounds overweight versus 50 pounds overweight. But each one of those subtracts points. So remember, we're starting at 35. So if you have a BMI of 40, that only subtracts 1 point. So you're down to 34. So unless you have other comorbidities to put you under sort of that magic number of 30, that does not automatically disqualify somebody from being an outpatient total joint arthroplasty. Right now, I'm the only one doing outpatient total knees in our group, but we've just started a whole program where I think in short order we're going to be doing hips, and other surgeons will be doing knees. Yes?
Will Medicare pay for the outpatient therapy?
Yes. Yeah, there's no difference between you know, the historic ways that Medicare pays for therapy, whether you're in the hospital 1 day, 2 days, or 3 days. So, you know, if you look at, there's enough knees done, 1 million total joints a year, that we look at the data, and if you do both at the same time, there is a slight increased risk of needing blood transfusions and extended hospital stay. You do both knee, you know, if you look at the difference, we do 1 knee, you're home in 2 hours. If Barb had both knees done, the standard of care now is usually you're in the hospital 2 to 3 days, and almost all bilaterals go to rehab, an inpatient rehab facility for 5 to 7 days. So you can be institutionalized for 10 days, you know, with bilateral knee replacements. So that increases your risk of hospital-acquired infections. It increases your risk of transfusions. It increases your risk of falling. You know, so extended anesthesia time, extended tourniquet time. So all those things, the pendulum has swung where we really, across the country, you know, as a specialist, have gotten away from that. Well, it's just like conformists. They're gonna just, you know, we had the head, you know, the head of surgery would say that it's safer in the hospital. Why are you risking sending them home? Look at the hospital acquired, you know, complications. So, you know, they're going to say that you're going to, you know, all you need is one bad result, and it's going to be flashed all over the newspaper. But it's why we just didn't start this and say, this is really cool, let's do outpatient joint replacement. I'm part of this SwiftPath national program. So as a group now, we've done over 600 outpatient total knees without one admission. So I didn't start this, but I was an early adopter of the SwiftPath program. Every step that we do has been vetted by 45 orthopedic surgeons that have voted on this. So this won't be a level 1 study, you know, that's in our journals for 10 years. But anybody that's interested, I was looking for our first video on YouTube, and I couldn't find my little video, so I put outpatient total knee arthroplasty YouTube, coordinated health. I was looking for it, but 20 YouTube videos came up of other docs around the country doing this, you know. So I have some great friends out in Columbus, Ohio, that, you know, Chicago, that are doing 1,000 a year like this. So, I mean, this has been around, and so we didn't recreate the wheel. We learned from people that do it successfully. But the critiques they don't know how to do it. So to put all this together, it takes a lot of work. It takes a team. You want to look at what works around the country. You want to be part of a national team, and that's sort of, you know, that. So, you know, I think any time we started aspirin, we started clavicle fractures, we started fish oil, we criticize the side effects of statins. Everybody will criticize that. But, you know, you just have to be honest to yourself. You look at the medical literature. We're like a living laboratory, because all I do are knees, so we do over 1,000 a year. So we just look at what works, and we use good judgment. So partial and whole knee replacements. Think of the knee as 3 joints, not 1 joint. The inside, the outside, and the kneecap. Each one of those can be a partial knee resurfacing. Think of it like part of a tooth. You can do a partial knee, like that first picture that I showed of Dan Hilt. He had a partial medial compartment. You can do the mirror image, a partial lateral compartment, or a partial patella replacement. They get the same preoperative education that a total does, because every partial we do, I never go in without the patient giving me permission to do the whole knee, because you get in there and you may find too much arthritis and go, oh my God, this is the wrong operation, but the patient didn't give me permission. So I have a big hole in the knee and I'm going to do a partial, but it's wrong. So we set everybody up the same way. A total knee replacement is what the operation is called. I said we should change the name to a total knee resurfacing, because unlike a hip replacement where you actually take the hip joint out and put a new ball and socket in the knee we're just replacing the cartilage. We're just putting a crown on the end of the bone. So, you know, a total knee is we resurface the whole knee. A partial knee is we just resurface part of it. So, you know, but total knees were, you know, invented 60 years ago, but what we do now has no resemblance to what we did 60 years ago, but it's still called the same operation. I said we should really update our terminology because it's confusing. Yes, ma'am?
What kind of fish oil do you recommend?
So, good fish oil. Good fish oil. You know, there's different fish oil. I always say that there's some good tests out there to to do it. But I like the natural triglyceride form of fish oil, and there's some, there are some good fish oils. One of our nurses was affiliated with PRN fish oil, but there's some good fish oils from Norway, that are natural triglyceride form of fish oil. And then there's some low quality fish oil that's not pharmaceutical grade that you can get in some of the warehouses that I would stay away from. If you cut it open and it smells bad and you can't stand it, it's probably a bad fish oil. Yes, sir.
What kind of activities after the procedure would you be limited to do, like running, biking?
Yeah. So really, there is no restrictions. I mean, you have people skiing, running triathlons, running races. Do I think it's a good idea? No. We sort of frown on running, impact loading, but there's people out there that want to do it, play some doubles tennis, that sort of thing. The younger you are, we want, the material properties of these knees go, decades. So if you put it in there, you want it to last the rest of your life. So probably, going on 10-mile runs isn't a great idea, but there are young people that get out there with, especially with the partial knees, and we really have no restrictions other than pain and swelling. Yes, ma'am.
Are they doing shoulder replacements the same way?
So I did an outpatient shoulder replacement when I used to do everything years ago, and that's what we did, and now I don't do that. But in 2002, 2003, I would do shoulder replacements as an outpatient 10 years ago. But shoulders are a little easier to do as an outpatient because you don't walk on your shoulders, you do a scalene nerve block and you go home. So really, any of these can be done with this multimodal approach. And upper extremity is a little easier. Same question. Yes, ma'am.
How long is the physical therapy afterwards?
So there's no absolute number. I would say there's people that do it for 2 weeks, there's people that do it for 3 months, probably 6 weeks is the average.
What do you use to hold everything together?
So we just use your ligaments. So, think of it like this. We just put a crown on the end of the bone. And we have different prostheses that take no cement where it grows onto the bone. 90% of the knees that we use, we don't use cement on, or we just use it on one component. It's called porous ingrowth. So it just grows, the back of it is kind of like a roughened sandpaper. It just grows right onto the bone. But there is a bone cement if people have osteoporosis or weak bone that we put in there too. Yes, ma'am.
I need a revision on a 2-year-old implant because the cement is breaking down. Now, you just mentioned non-cemented. Is that something that possibly is going to work?
So if you think in the hips, everything is unccemented. The whole pendulum has swung, In the knee, I think, again, we're sort of ahead of the curve in using uncemented components just because you eliminate the variable of cement breakdown. But even on revisions, we do a lot of uncemented knee revisions that are uncemented or use minimal amounts. Yes, ma'am.
After several years of cortisone shots and my husband getting the rooster shots, how far can you do that until knee replacement is needed?
So I always said 50 years ago there were no knee replacements. So the human race did pretty good for 150,000 years without knee replacements. So, what did they do? They slowed down, they used a cane, they used these nice walker devices. So, the decision is up to the patient. The decision is a quality of life and how much they want to put up with. Now we have the technology and the protocols to improve the quality of your life, but there's no absolute answer. Most people, when it starts working less than 2 or 3 months, their life is pretty miserable. You go through, we have a whole list of non-operative criteria that you must have gone through before the insurance will pre-cert you. But it's the anti-inflammatories, the injections, the braces, the assistive devices, and then when your life is pretty miserable, that's when people decide.